Welcome, everyone. For those that don't know me, my name's Joanne Occhipinti. I'm Head of Systems Modelling, Simulation and Data Science at the Brain and Mind Centre of the University of Sydney, and also Managing Director of CSART, which is an alliance of Centres of Excellence in Systems Modelling across 5 countries. So I'm delighted to be here in Lugano, finally in person. I've travelled here from Australia with my colleagues, Dr. Ante Prodan and Dr. Adam Skinner and Professor Mark Heffernan up the back there. And over the last 7 years, we've developed over 40 systems models in partnership with national and state policy agencies and regional program planners across a range of areas, including alcohol-related harms, tobacco control, childhood overweight and obesity, chronic disease prevention, as well as child protection, homelessness, and we've got a growing program of systems modelling in mental health and suicide prevention. So these models, while they're well used in infectious disease control, are not routinely developed to inform other population health and social problems. And so what first attracted me to systems modelling is the idea that rather than making public health decisions on the basis of individual pieces of a complex puzzle, they instead provide a systematic process for bringing together the key pieces of the puzzle into a single model. And these models really require us to articulate our best understanding of a complex problem by bringing together best available research evidence and data and expert and local knowledge into an interactive decision support tool. And this can not only help us better understand the likely impacts of public health decisions and investments before they're implemented in the real world, but they can also help us understand what the implications are of what we still don't know. So one of the misperceptions we often encounter is that systems modelling is only feasible in high-income countries such as Australia, where the quality and quantity of data is perceived to be greater. But we strongly believe that these kinds of models are even more important for informing investment decisions in resource-constrained countries. So we were extraordinarily grateful to Foundation Botna for funding youth mental health systems modelling work in Bogota, Colombia, which provided the opportunity to really demonstrate what's possible. And you'll hear about this work today. So it's my pleasure to introduce to you today Dr. Adam Skinner, Senior Research Fellow and Systems Modeller at the Brain and Mind Centre of the University of Sydney, who will be talking about a tobacco control model he developed that was commissioned by the Health Department in Queensland, Australia, and who was also the architect of the Youth Mental Health Systems modelling in Bogota. You'll then hear from Dr. Laura Ospina-Pinillos, who is a child an adolescent and family psychiatrist and assistant professor of the Department of Psychiatry and Mental Health at, I'm going to pronounce this very badly, Pontificia Universitat Javeriana. Oh, that was terrible. I'm sorry, I killed it. And Laura is going to speak about the participatory systems modelling work that she really led in country. And finally, you'll hear from Dr. Salvador Camacho over here of the Systems Performance and Monitoring Unit of the Swiss Centre for International Health at Swiss TPH. And Salvador will be presenting some preliminary results of the evaluation of the participatory modelling process in Bogota. So without further ado, I might hand over to Adam to get us started.
Okay, so thanks, Joan. Thanks, everyone. Thanks, everyone, for being here. So this evening, I'm going to present the results of 2 separate but related projects, both of which apply dynamic modelling to the problem of reducing or more ambitiously eliminating tobacco-related harms. So the first is a very practical, large-scale participatory modelling project commissioned by and undertaken in partnership with the Queensland Department of Health. The second project's a more theoretical analysis of the potential for hardening in smoking populations exposed to effective tobacco control programs over an extended period. So probably nobody here needs convincing that reducing the harmful effects of smoking remains a global public health priority. So nearly 6.5 million people are estimated to have died from smoking-related diseases in 2015, which corresponds to about 11.5% of global mortality that year. So despite this appalling statistic, substantial progress has been made in reducing smoking prevalence over the past 30 years. So between 1990 and 2015, daily smoking prevalence declined from 34.9% to 25% among men, and from 8.2% to 5.4% among women. And as the maps on the right, taken from a 2015 paper in The Lancet show, continuing declines in smoking prevalence are expected for many, although certainly not all countries over the next decade. So smoking prevalence in a growing list of countries has declined to less than 20%. Many public health researchers have advocated for a shift in the emphasis of tobacco control efforts from minimising tobacco use to eliminating it entirely. So these researchers have proposed a range of so-called endgame strategies for phasing out tobacco products, although many of the proposed approaches have never been implemented. And other researchers have expressed concern that novel, untested interventions are being overemphasised in endgame planning at the expense of existing policy approaches that have proved effective in reducing smoking prevalence to date. So the issue of exactly how to approach the task of promoting a rapid decline in smoking prevalence when smoking prevalence is already low was a principal concern of the Queensland Health Department when, in 2017, they commissioned us to build a dynamic model to support the tobacco control strategy development. So for those unfamiliar with Australian geography, Queensland's the third most populous state in Australia, with a resident population of about 5.3 million. So that's about 20% of the total national population. So approximately 424,000 Queensland adults, including 12.2% of men and 10% of women, were daily smokers in 2018. And the Queensland government's invested in a wide range of tobacco control initiatives that have contributed to a significant decline in smoking prevalence over the past 20 years. Despite this progress, however, there's a concern that without well-directed ongoing investment in smoking reduction measures, it's going to become increasingly difficult to achieve further gains. So over a period of about 6 months in late 2017 and early 2018, we developed a system dynamics model of smoking behaviour and tobacco control in Queensland using a participatory approach that involved a broad range of local and national stakeholders. So this included representatives from state governments, health and social policy agencies, research institutions, and community and consumer groups. And our primary objective in building the model was to enable policymakers to assess the ability of those tobacco control measures that were already in place to sustain a rapid decline in smoking prevalence, also to explore the potential for further reducing smoking prevalence through additional policy interventions, and to examine the potential consequences of redirecting resources from existing tobacco control initiatives to novel endgame approaches. So the analyses I'll present here focus on 3 policy interventions that were at the time of particular interest to Queensland Health, although the impacts of a range of other interventions can also be explored using the model. So the 3 focal interventions involve increasing the current level of anti-smoking mass media campaign exposure, introducing a tobacco licensing scheme that would require wholesalers and retailers to apply for a licence prior to supplying tobacco products, and increasing the minimum age of legal supply of tobacco products from 18 to 21 years. So we compared 8 alternative intervention scenarios shown on the right of the slide, with a business as usual, a baseline scenario that corresponded to business as usual, in which all tobacco control measures that are currently in place remained unchanged until the end of the simulation. So the diagram presented here provides a high-level overview of the dynamic model structure, and it indicates where the three interventions, which are highlighted in red, have their direct effects. So core model components capture age-specific numbers of current smokers and ex-smokers in the total Queensland population, initiation among adolescents and young adults, and cessation and relapse. So the arrows indicate causal dependencies among these and other model components. So for example, initiation increases the number of current smokers in the population, while current smoking prevalence affects the initiation rate through peer influence and the effect of parental smoking. Similarly, the numbers of current and past smokers in the population determine rates of hospitalisation for smoking-related diseases, which partly determine the cessation rate, since adverse health events will tend to prompt a cessation attempt. And at the same time, cessation and relapse alter the numbers of current and ex-smokers in the population, which affects not only the initiation and hospitalisation rates, but also the cessation and relapse rates themselves. So anti-smoking advertising and tobacco licensing are assumed to directly affect initiation, cessation and relapse, whereas an increase in the minimum age of supply is assumed to only affect initiation. So we assess the ability of the model to reproduce system behaviour by comparing model outputs with a broad range of empirical data, including population and demographic rate estimates, age-specific data on current and past smoking prevalence and smoking-related behaviours, and estimates of hospital separation rates for smoking-related diseases, including lung cancer, COPD, acute myocardial infarction and stroke. So some example comparisons are presented in the graphs on the right of the slide, where the empirical data is plotted in grey and the corresponding model outputs are plotted in red. So this slide presents simulation results for 6 of the 8 intervention scenarios that we considered in our analyses. Under the baseline or business as usual scenario, which is plotted in grey in each graph, adult daily smoking prevalence is projected to decline from 11.8% in 2017 to 5.58% in 2037. A sustained 50% increase in anti-smoking advertising exposure from 2018 reduces smoking prevalence in 2037 by 0.8 percentage points, so compared to the baseline projection. And similar reductions are projected for tobacco licensing schemes that either permit or prohibit the sale of tobacco products by alcohol licensed venues. So although increasing the minimum age of supply of tobacco products from 18 to 21 years significantly reduces the initiation rate, as we'd expect, the projected impact on smoking prevalence is negligible. And mostly this is because the number of adolescents entering the smoking population each year is already very low relative to the total number of adult smokers. And lastly, a sustained reduction in anti-smoking mass media campaign exposure of 50% from 2018 increases the projected prevalence of smoking in 2037 by 0.88 percentage points, while complete disinvestment in mass media campaigns, so a 100% decrease in exposure, increases projected prevalence in 2037 by 1.98 percentage points. So our modelling indicates that the comprehensive set of tobacco control strategies already in place in Queensland is sufficient to sustain a rapid decline in smoking prevalence. Nevertheless, there's considerable potential for accelerating this decline through additional policy interventions that can encourage cessation and reduce the chance of relapse among existing and past smokers. Perhaps most importantly, our simulation analyses indicate that disinvestment in existing tobacco control measures, such as anti-smoking mass media campaigns, has the potential to impact substantially on future trends in smoking prevalence, which suggests that any prudent approach to endgame planning should seek to build upon rather than replace conventional policy interventions that have proved effective in reducing smoking prevalence to date. So now I'll turn to the second project, examining the expected impacts of tobacco control programs on population level measures of nicotine dependence. So as I'll try to explain, the results of this analysis help to provide support for the conclusion drawn in our modelling for Queensland Health, that a multifaceted tobacco control program is capable of sustaining a rapid decline in smoking prevalence, even when prevalence is already low. So the reason for questioning this conclusion, which has significant implications for tobacco control policy decisions, relates to the so-called hardening hypothesis, which proposes that average nicotine dependence in a smoking population is going to increase as less dependent smokers quit more easily in response to effective public health interventions than heavily dependent smokers. So these interventions effectively sift out people who are able to quit, leaving behind an increasingly dependent population of smokers, and in the process, they become increasingly less effective. So proponents of the hardening hypothesis have argued that sustained progress in reducing smoking prevalence is going to require a shift in the emphasis of tobacco control programs towards intensive treatment of individual smokers. Nevertheless, while it may appear self-evident that average nicotine dependence should increase as less dependent smokers quit at a higher rate than heavily dependent smokers, analyses of population survey data from the United States, Europe and New Zealand provide no evidence that significant declines in smoking prevalence are associated with declines in the motivation or capacity of smokers to quit. So to better understand the impacts of effective tobacco control measures on population level nicotine dependence, we ran a series of simulation experiments using a simple dynamic model of smoking behaviour to examine the effects of changes in per capita rates of initiation, progression to heavy smoking, cessation and relapse on the proportion of smokers in a population who are heavily dependent. So we also examined the impact of a multifaceted tobacco control program on the proportion of heavily dependent smokers in a real world smoking population by fitting the model to population survey data on smoking related behaviour in Australia using Bayesian Markov chain Monte Carlo methods. So the dynamic model used in the analyses includes three core stocks or compartments corresponding to the numbers of less dependent smokers, heavily dependent smokers and former smokers in the total population. Initiation and relapse add to the stock of less dependent smokers, while the number of heavily dependent smokers increases as less dependent smokers progress to heavy smoking. So less dependent and heavily dependent smokers flow into the stock of former smokers as they quit. And we've assumed that the per capita cessation rate for heavily dependent smokers is equal to the per capita cessation rate for less dependent smokers, multiplied by a constant rate ratio that's substantially greater than 1. So what this means is that whatever else happens in the model, the per capita cessation rate for less dependent smokers is always much higher than for heavily dependent smokers. Differences in mortality rates are captured in the model in a similar way. So less dependent smokers have a lower per capita mortality rate than heavily dependent smokers and a higher per capita mortality rate than former smokers. So for me, this is the most interesting slide of the whole presentation because it shows that persistent increases in the per capita cessation rate ultimately produce a decrease in the proportion of smokers who are heavily dependent. So this is the graph labelled cessation. So this is exactly the opposite of what the hardening hypothesis predicts. Moreover, we can see that larger increases in the per capita cessation rate are expected to produce larger reductions in the proportion of heavy smokers in a smoking population. So the simulations that I presented here show the effects of a 10% increase in the per capita cessation rate, a 20% increase, a 30% increase, and the line at the top is a 10% decrease. So we can develop some intuition about what's happening here by noting that an increase in the per capita cessation rate doesn't only increase the number of less dependent and heavily dependent smokers flowing into the former smoker stock per year, It also reduces the numbers of less dependent, reduces the number of less dependent smokers becoming heavily dependent smokers per year, since this just depends on the number of less dependent smokers. And it increases the flow of former smokers into the less dependent smoker stock due to relapse, just because there are more former smokers. So the combined effect of these changes in rates of flow between alternative smoking states is an increase in the number of less dependent smokers relative to the number of heavily dependent smokers, and therefore a decrease in the proportion of smokers who are heavily dependent. So reductions in the per capita rate at which less dependent smokers progress to heavy smoking also result in a decline in the proportion of heavily dependent smokers in the smoking population, while decreases in the per capita initiation and relapse rates lead to temporary increases in the proportion of smokers who are heavily dependent. So when we fit the model to population survey data on smoking-related behaviour in Australia, which are plotted in red in the graphs, we see that a decline in smoking prevalence from 23.2% in 2001 to 14.7% in 2016 was accompanied by a substantial decline in the proportion of pack-a-day smokers in the smoking population, which is consistent with the results of both previous empirical analyses and the simulation experiments that I showed on the previous slide. So despite its intuitive appeal, the principal argument underpinning the hardening hypothesis fails to take into account the indirect effects of an increase in the per capita cessation rate, and it doesn't hold generally. So our simulation experiments demonstrate that public health policy measures that are effective in promoting cessation will ultimately contribute to a decrease in the proportion of smokers who are heavily dependent, not an increase. We therefore find no evidence to support a shift in the focus of tobacco control strategies towards intensive treatment of individual smokers. Rather, we conclude that public health interventions that have so far proved effective in reducing smoking prevalence, including mass media campaigns, tobacco tax increases, and smoke-free environment legislation, will also contribute to a continuing decline in population-level nicotine dependence. So before I finish, I'd just like to acknowledge my co-authors and members of the Queensland Tobacco Modelling Group, all of whom contributed to the work I presented this evening. Thanks so much for listening.
So I guess that we're taking questions after. Thank you so much for joining us right now. It's 5 p.m. I know that you're all tired after courses and courses. I feel extremely happy to be here with you today to share the experience of what we have been doing in Colombia, and extremely grateful with the organizers for inviting me and with the Australian Swiss team that has collaborated in this project. So today I'm just going to illustrate how we used systems modeling to improve mental health outcomes in young people in Bogota. So I know that you all know about this. Yes, it's changing. Yes, you all know about this, but I just want to provide you a little bit of context of why systems modeling was important in a country like Colombia. So we know that low and middle income countries we all have, of course, mental health problems, but the scenario in low and middle income countries is that we host the majority of the people and also the majority of the young people. So actually making interventions and actually doing efforts to reduce mental health problems in low and middle income countries become really, really prevalent because of the population that we host. Despite the large number of the population, just 20% of the mental health resources are invested in these countries. And the treatment gap, that means if I need to see someone to get treatment for my mental health problem, if I get it, the mental health treatment gap in low and middle income countries is around 50% for the entire countries, but it could be as high as 90%, and I will present you more details about the Colombian scenario. We also have, as I was telling you, a majority of the young population, but it's very important to know that 75% of the disorders have their beginnings before age 25. So that also makes us a point of why to invest on young people's mental health. And suicide, of course, is getting more and more prevalent, and in some countries is the first cause of death among young people. For some of the countries is the second cause of death, and that makes really important to understand how the need needs to be met in order to get effective care. However, there is a scarcity of resources, there is a scarcity of mental health professionals, there is a scarcity of mental health care across all countries, but specifically in all middle-income countries. Colombia has 48 million inhabitants, and 36% of the population is under 19 years old, and 46% of the population is under 25. The prevalence of mental health disorders is 7.1, and for adults is 9, and the treatment gap is 60%. That means that just 40% of the people that would need to see someone could see someone. 60% is not seeing anyone. And of course, we are a middle-income country, a high middle-income country. But this is really important to stress out, is that the Gini coefficient is 54. That means that we are basically one of the most unequal countries in the world. And the GDP, the amount of money that we invest in the GDP is 4.1 of the GDP. That means to health, to mental health, it could be 0.7. So there is a great need to urgently develop services and care for young people. But how can we actually meet the need? How can the policymakers actually take the right decisions to actually met this need? And this is where systems modeling makes a case. So by systems modeling or using systems modeling, we could inform our policymakers to actually take a better understanding or take a better guess of where to invest all the resources and the efforts, because it's just not about money. It's also about health professionals. It's also about workforce, where to invest these resources to get better outcomes. So there's an urgent need to inform policymakers on what are the strategies that would reduce these outcomes and in young people, and where to implement these programs, the programs or the interventions. So whenever we started this project in 2019, there was a lot of uncertainty saying that perhaps we cannot do systems modeling in a country like Colombia because there is limited data sources, because the quality of the data is not very high, and also because there's a limited understanding on system modelings and how this can inform decision making. And that's the reason why we decided to prove wrong all the people that were skeptical, and also that's why we actually make a participative approach to develop this model in Bogota, Colombia. So part of the process, and then Salvador is going to talk a little bit more about the monitoring and evaluation of the participatory component, is to involve stakeholders to the development of the model. For those who are joining the course of modeling, you already know how important it is actually to get data sources, but we also need to get information from stakeholders to actually create the model, to get better data sources, but also to get them learning about how systems modeling work and actually trusting a model that then can serve for them as a decision support tool. So we did a participatory process. We ran 3 series of workshops across the time. In the first workshop, participated 57 participants. In the second workshop, 43. In the third workshop, 55 participants. But the scope of each workshop was different, and I'm going to explain you what we did. What were the stakeholders? Who were the stakeholders involved in the creation of the model? We're talking about mental health in young people in Bogota. So everyone that basically has to do with something related to mental health in Bogota. So child protective services, people in the education sector, people in the health department, people that work as health providers, people with insurance companies, mental health clinicians, NGOs, primary care, people that are representative of special groups, of course, academics, other journalists. So if we're doing a model, we want this model to be rolled out and we want journalists to know about this. But the most important group that participated were people with lived experience. So actually in the same room, we had people with lived experience and their carers to have a say of how this system model should work and should do. It was not just about doing the workshops. We also had to run several interviews to engage the different sectors and to get the most of the information of the people. So we host several one-to-one interviews with different sectors, basically government sector at the national level and also at the regional level, but also people that were like involved into this building process. So the first myth is that in a country like Colombia, we don't have data. That's wrong. Yes, we do have a lot of data. We're collecting a lot of data. The thing is that the data is fragmented. So we had to make an archaeologist kind of work to try to find out what were the databases that would work to inform the model. We end up finding 180 data sets that could inform this model. And it was also important that during the participatory process, a lot of the stakeholders donate data. So if the data wasn't available on online free access resources, some of the stakeholders with the process trusted in us, and then actually they give us this privileged information. So what happened in the workshops? The first workshop is the most informative workshop. In this first workshop, we mapped what were the outcomes. So the model cannot respond to all the mental health outcomes, and the model cannot include all the mental health evidence-based informations. So by working with people, we could realize what are the outcomes that they're more interested in reducing or in improving, and what are the interventions that they actually want to see the effect in the model. So this is like all the people in the room talking between each other and actually putting in sticky notes and in writing what are the social determinants of health, what are the things that are going to be built inside of the model, but also what are the interventions and what are the outcomes. So yeah, this is basically what I already told you. So the main outcomes that the stakeholders were interested were of course those related to reduce suicide and suicide attempts, to reduce the mental health prevalence of problems, and also substance use problems. And because in the Colombian policy, mental health is more than mental health disorders, they wanted some positive outcomes, such as quality of life or life satisfaction, sorry. So in the mapping exercise, and this is very important because the mapping exercise would guide what the model needs to include. So the people selected several social determinants or sections that they were after included in the model. Adam, that was the architect for the model, had a lot of fun building this model. But at the end of the day, the model has 13 sections interconnected and sections that are very specific to Colombia. So for example, a section related to poverty. If we're modeling something in a middle income country and an unequal country, poverty is something that we definitely have to take into account. For you that you all might know, but for those who doesn't, Colombia has more than 15 years of internal conflict. So actually violence was very important to be modeled in the process. And also other determinants of health, such as internal displacement. We are the first country in the world with more internal displacement. So those were sections that were included in the model as well. What were the interventions that people were interested to see the effect in the model? Interventions related to health provisions, such as training GPs in suicide prevention, or for example, having psychologists or mental health professionals inside of schools. We're talking about young people, so we have to talk about schools. And what are the community and other community-based interventions, such as having awareness campaigns, having training for gatekeepers. Gatekeepers are the people that are actually in the ground working with the community, such as priests, the people who actually sell the food in the stores, sports coaches, hairdressers, and so forth, so on. And the other thing is the organization of the services and how services, if they are working together, the impact of this in the mental health outcomes. In the second workshop, we actually got all these interventions and we defined specifically which intervention could we map. And we started to build the economic component model. We had a health economist to actually cost everything inside of the model in the interventions, and that's also a part of the project. In the third workshop, and this is part of actually gaining the trust of stakeholders and getting their feedback. In the third workshop, we presented them with the alpha version of the platform, of the model, and then we got feedback from them, and they also got familiarized with the interface. So as simple as actually showing them where to run, where were the interventions, like providing them with this instruction panel was really important to actually gain the trust of them and actually get them know about the interface. So behind this beautiful interface that stakeholders can interact with, there's a very complex mathematical model that you want to know more, we can provide a lot of feedback. But behind this, there's a mathematical model, but also a very easy to use interface for stakeholders to actually take to use as a decision support tool. Finally, the 15th of July of this year, we started to the first workshop in March last year, 2021, and the final launch of the model was in the 15th of July of this year. We got 70 in-person attendees and 17 virtual attendees. Some of you might be a virtual attendee here. And it was great that we got the involvement from people from the local government. So this gentleman here, can you see my, no. This gentleman is the chair of the health district, the local health district. And the lady here works for the Ministry of Health at a government level, all of them talking about how this model can help to inform decisions. So the simulation results for Colombia. What are the possible best interventions or combinations? Something that systems modeling can do is to actually map the effect of individual interventions, but also a combination of interventions. If I am the policymaker, and if I have to actually put a budget on every intervention or say which intervention do I have to know which interventions I'm going to invest on, but also what are the best combinations. And here the take-home message is that not all the interventions at the same time are as efficient. Sometimes we just find that the best combination is just 2 or 3 interventions. If we do more, there's not much of an effect. And that systems modeling can help us do. So at the individual level, the best interventions to reduce suicide and suicide attempts are those interventions in school, so school-based mental health programs and gatekeeper training. Of course, if we're talking about community, all the children, all the adolescents are in the community. So every intervention that we do at the community with a good effect, we're going to see a lot of positive results in a big scale. This is also very important because we have to know that our human resource in mental health care is limited. So actually, because the care is limited, we could train a lot of people in community and then we're going to have great effects. So between the individual effects of school-based interventions was very similar, around 28% to reduce suicide deaths and suicide attempts, and the gatekeeper training around 22% for both. So this shows you like the individual interventions and their effect, and this shows you the best combination. So the best combination in the Bogota case is running school-based interventions embedded in mental health in the curricula, run anti-bullying programs, like usually mental health programs will go with anti-bullying programs, do some gatekeeper training, and also escalate suicide helplines. Very similar results for suicide attempts. Then, if I'm a policymaker, if I have to take decisions of what I'm going to implement first and what are the programs that it could wait for later, we have to know that also implementation makes a difference, the implementation order. So I showed you already that the best combination was school-based, anti-bullying, gatekeeper, and helplines. This is the red run here, but the order actually makes a huge difference if I'm planning to see results in a short run or in a long run. Basically, it really depends on what do you have already in place and what is the effectiveness of each individual intervention. But just to provide you an example, if we start doing the interventions that have a better effect, so school-based and gatekeeper interventions straight away, it will have a better effect than if we do the other ones that have smaller effect. It's logical, no? Then another very important thing in our context is sustainability. Like we have experienced that every now and then with policy change, when policy changes, when decision makers change, the sustainability of the programs is jeopardized. So this is actually the effect, and this is very informative for a policymaker, that actually if you don't sustain, the effect is not going to be reached. So this is the effect if you suspend the funding for an intervention that should be effective. This is calculated for a 4-year time set. So we already talked about suicide attempts and deaths. So now we're going to talk about mental health problems and substance use problems. So what are the best possible interventions to reduce mental health problems and substance use? The best interventions are for mental health problems, anti-bullying programs, GP training about mental health, and community connectedness. And I really want to stress here the value of community connectedness programs in reducing both substance use problems and mental health problems, and it actually makes a lot of sense. If you put young people in the community making a better use of their free time and doing something that it's meaningful for them, it will be very, very preventive. So here is just, again, to show you the possible best combinations and to show you that more is not merrier. Is that correct? More is not the merrier? No, well, whatever. If you don't, you don't have to do everything to nail the outcome that you need to do. So actually, these two runs show you so for example, in pink, you can see school-based interventions, anti-bullying programs, and community cohesion would have a very similar effect that if you put more interventions. So school, anti-bullying, gatekeeper, helplines, and community cohesion. So this is very informative for stakeholders. So they just don't shoot to whatever they can. They just have to nail the things that matter. Very similar scenario for substance use problems. And all of this, we can make a beautiful interface, we can make a beautiful model, but this doesn't mean anything if actually policymakers don't take it and use it. So these are some preliminary things that have happened since we launched the model. We launched the model a month ago. So after that, we had a lot of tweeting from the health district about how informed decisions would have better outcomes. So that's the head of the local health district. And we have also hosted different meetings with different organizations they're trying to know how this model could work for their needs. This IDPRON is an agency that deals with vulnerable populations, vulnerable youth. so how this model could inform what their plans for their actions. We also got a lot of academics very interested in how modeling works and participating in this process. So 2 LinkedIn mentions. We also got the attention from universities. And as you all know, like, we cannot sit and wait until the government makes things, right? The decision-making needs to be impulsed in several directions. So that's why we have started to meet with schools, because we know the effects of school-based interventions. So we actually have to start to meet with schools. This is a group of schools and actually a kindergarten that are very interested in the results, and they really want to implement mental health programs in their curricula. So we're pushing in all the directions from top to down, down to top. If you ask me, I think that it's going to be really easier to implement down to top. And that's the work that we have been doing. And we also hit the news of these very exciting results and very exciting projects. So actually, we're trying to get a lot of awareness to make the government take this. So what are the next steps? Of course, we built this with the incredible help of the University of Sydney, CSARS, and the Swiss TPH. We have to create a lot of capacity in Colombia to be independently running this kind of analysis. We have to still adapt and create more models to different contexts and populations. The model that I just presented is to the capital city in Colombia, Bogota. So we still have to do some modelings and some understanding on rural populations, on mid-towns. We have to understand the impact in decision making. I would love to see, like, in 2 years' time, if they actually take it and make decisions based on this. And we have to keep updating the model. Like, we know that perhaps every year we need to update this model and then start stratifying the model as much as the data allow us. So in conclusion, system modeling is a decision support tool that can be, and if you ask me, it should be co-constructed with stakeholders. And it would be in order to get evidence and local knowledge of the model and actually to guarantee the take-up of this model. So it's also a transparent process when we involve all stakeholders in the same room. Actually talking about this makes it transparent. And then the other very important thing is that after the symposium, when we launch the model, we give everyone that participated in the workshops username and a password to have access to this. It's not that we're holding this information as the Holy Grail. The model is available for everyone that wants it. And of course, we would like to know how to interpret the results and use it. And well, it can be versatile, it can be modifiable, we can change the effect sizes for those who have been in the course. That's something that you already know. And we have to define where are the best combinations according to the context, and actually realizing that not all the intervention and hitting all the interventions is the best approach. I would like to thank all of you for the attention, but I also would like to acknowledge the big research group that is behind this in Colombia and across the globe. Yeah, my details if you need something.
So good afternoon, everyone. My name is Salvador Camacho. I work for Swiss TPH, and I have the honor to present our work from my colleague here present, Adriana Martin Gilbert, and myself. And yeah, we're part of this fantastic team, and we're very privileged of that. Thank you very much. And also thank you to the Lugano Summer School for providing us this space to talk about this work. And so, yeah, our task in Swiss TPH was to evaluate what was the value that the participants had from this whole process. So just linking to what Laura was saying, that it was not only about building the model, but then assuring that the people involved will make use of that and they will acquire some other profit, so to say, out of this whole process. So we tried to evaluate that. And the first thing that we did was a very straightforward survey, baseline inline survey. So which I guess will make a lot of sense. So we used this Charles framework, which was very appropriate for the process because it basically measures the what happened or how the people changed their perceptions and their ideas or preconceived ideas once they are exposed to a discussion or arguing around these concepts. So the first thing that we did was we had these two research questions, which was what was personal experience of participation, decision making, and systems model development. And this included, of course, motivation and engagement for participating in such a process, the learning that they acquire of such a process, and the group level consensus process, personal experience using the model, etc. And the second research question was what were the stakeholders' perspective on the utility of the model, knowledge and beliefs about adolescent mental health care, and perceptions of driver of systems performance, which included model credibility, perceived ability to modify the reach and effectiveness of the interventions, and the perceived value of the actual model. So I'm not going to go much into detail here because you already heard that from Laura, that it was a very varied group of stakeholders, basically representing the whole network. And only to highlight here that most of them were either in direct contact or were themselves persons with lived experience, which was super enriching the whole participatory process. So what we got from this survey that we did, the baseline endline survey. So we asked in the baseline that what were their expectations, for example, related to the opportunity to have their voice heard. And not a lot of people were very excited or were waiting to do that. And at the end, it happened that a lot of the stakeholders group actually felt that their voice were heard. So this was very, very nice to find out. And also, we asked whether they were expecting that this process will increase their knowledge of the mental health services available for young people in Bogota. And we found more or less the same effect, that not a lot of the stakeholders were very positive on that. And in the headline, a lot of them felt that indeed they had a better understanding of the health services. Another one was whether they have had contact with other services organizations that otherwise they will never have during this process. So we asked them, do you expect to have these contacts through this process? And again, not a lot of them were super excited about it or not expecting that. And at the end line, it happened that a lot of people found that they indeed had contacts in this that otherwise they will never have. So that was basically the very, very straightforward. What are you expecting? What did you get? But also trying to cover a different aspect of this kind of evaluations. We did a social network analysis of this Bogota mental health network represented by the stakeholders. So we had our hypothesis that participation in the workshops may have expanded or altered in some way their pre-existing social network and also their relationship. So the method of verification that we used was this social network analysis in a very basic measurement. So these were the metrics that we assessed that not to go too much in detail, we counted all the stakeholders that they were, and every one of the stakeholders were representing a node. And then we find out the relationship, who is connected to whom, in what sense, how strong is this link, and who is receiving more connections and who is sending more connections, and the distance between two that are somehow secondarily connected, or those who are directly connected, etc. So long story short, those were the basic measures that we used. And we found, not surprisingly, that there are two main actors in the whole network, which were the Health District Department and the Ministry of Health. So I guess this is not a surprise for anyone. And also these same two actors were the ones with the higher visibility, and they were who spread more easily this information, whatever that may be, among the rest of the stakeholders. So that was not surprise because this is a very rigid structure. So that was also straightforward. But what we found surprisingly was that once we took a look at who were the elements that were less connected but gained exposure through this process, then we found that there was substantial changes. So for example, in the baseline, the participants identified the School of Medicine of Pontificia Universidad Javeriana, Colombian Association of Bipolars, Colombian Association of Occupational Therapy, and Colombian Association of Psychiatry as less connected but yet influential elements among the stakeholders. But in the end line, they identify completely different elements or different stakeholders than that. And the same happened with the elements that they consider as the most influential ones, which were measured by a measurement called MICMAP, influence. And they also change dramatically from the baseline to the end line. So again, in the baseline, they identify the ones in the green chart, and in the end line, they identify the ones on the orange chart, which were completely different. This is a depiction of the actual social network on the baseline to the left and on the end line to the right. And as we can tell, this is totally rigid structure, so there were no major changes in that sense, but the changes were inside the dynamics of the links between them. So that could explain all this identification of different influential people who were the ones who gained exposure, etc. And that also may explain that all of a sudden, some of these stakeholders were very open to share their data or to participate in different ways. So the conclusions here that we got from is that, of course, the general structure of the network did not change, but since other measures indeed have a lot of changes, we may suggest that indeed the workshops may have altered the perceived role of certain stakeholders. Like in this case, once they understood what the other guys were doing, and probably they were stakeholders that they never had contact with before, and they understood the role they have inside this whole network, then they appreciate more the work, the role inside what they do, how their work is connected to the other people, etc., etc. And we think that this will make the network to gain efficiency also in the work that they are doing. And the participatory nature of the work, the workshop may have facilitated contact and understanding of the multiple actors within the system, which is basically what I just said. So our main conclusion is that indeed this process added a lot of value in parallel to what was done in the actual model. So we certainly consider that this process was totally a success. So yeah, thank you very much.
What we're able to do is essentially test different scenarios. Like what if we could, what if we need to build service capacity first and then implement awareness programs to drive more people in that system? And that has a synergistic effect in the model. So it's not always about whether something works or doesn't, but under what conditions will it be a good investment?